Welcome everyone to our journal club for this month. We have a very exciting topic on third window syndromes, diagnosis and rehab considerations with our wonderful guest, Dr. John Patrick Carey from Johns Hopkins, and I'll let him introduce himself a little bit more. I'm Helena Esmond, as always, physical therapist and your host.
Hi, good morning. It's morning here, and I'm really pleased to be here and excited. I'm John Carey. I'm an otologist, neurotologist at Johns Hopkins. I came here in 1998 to work with Lloyd Menière because he had discovered this crazy new thing called superior canal dehiscence syndrome. And, I was honored to get in on the ground floor, and he got busy academically, and I ended up taking over that practice over time. And so we have a pretty healthy practice of patients from all over the US and the world with superior canal dehiscence syndrome. So excited to share my thoughts about it.
Yeah, and we're very lucky to have you because you certainly have been boots on the ground for this topic, as they say, and it has evolved quite a bit, I believe, in the literature over time, which is always good to see so we can help our patients with these challenging conditions as much as we can. So the article we're going to specifically talk about, and then we're going to kind of come off of it a little bit and talk more about some other considerations, but I want to make sure that we spent a bit of time on the most common of the third window syndromes, which is superior semicircular canal dehiscence. And specifically, the article that we chose is on the diagnostic criteria, of which you are one of the authors of that article. And I love to start every journal club with a really super quick vestibular anatomy, trying to let everyone get on the same page if they're not. So we're talking about the inner ear. We're talking about our vestibular system. That is a beautiful balance sensor that lives deep in the inner ear. It's neighbor to quite a few hearing structures, which is particularly important with this condition, actually, of superior semicircular canal dehiscence. But in general, it is an important sensing organ for balance. And that organ, we have one on the left and one on the right typically, will send information to the brain and integrate, hopefully, information from our eyes and our proprioceptive sensors in our joints that tell us where our body is in space, get all that information together so that the brain has a very good sense of where we are in the world and keeping us safe. And that is if everything is working according to plan as it should. Most of our journal clubs, we do talk about what can go wrong, but only in the context of trying to help folks who have different various issues in this system so we can help that person feel better. So third window syndromes describe a set of vestibular and or auditory, because remember that vestibular system is neighbor to the hearing structures. These kind of symptoms from either or both systems having an issue when there are defects in the integrity of the bony and or membranous structures that can change the pressure inside the inner ear. And I kind of put what I found on my searches to be the top three that I was aware of, which is superior semicircular canal dehiscence, although I understand that other canals can also have dehiscence, meaning our horizontal or posterior canals. Also, perilymphatic fistula seems to be a more commonly discussed third window syndrome, and then enlarged vestibular aqueduct. There are other less common ones. Is that correct, Dr. Carey?
That's right. I think you've hit on the major ones. Um, we see openings on high resolution CT between the carotid and the cochlea, for example, between the facial nerve and either the cochlea or the lateral or horizontal semicircular canal. But clinically, those aren't that common in presentation.
Understood. Understood. And as far as presenting with vertigo or dizziness as a potential symptom, this is how I think I've become more familiar with superior semicircular canal dehiscence, because that condition can have that sort of symptom as kind of dizziness or vertigo at times. Perilymphatic fistula may also have a presentation that includes dizziness or vertigo. What about enlarged vestibular aqueduct? Do we see dizziness with that very much?
Yes, I don't see as many of those patients. They often present in childhood.
Ah,
Um, Many of them will have progressive hearing loss and go on to cochlear implantation. Um, I would say they don't often have a distinct vestibular phenotype, and that may have to do with the the fact that there's not a vestibular sensor per se along that tract where there's probably abnormal flow. So one of the
understood.
things that makes superior canal dehiscence so uniquely diagnosable is there's an all hands on sensor, the ampulla and the crista, the superior canal, that is poised to detect flow in that canal. And it's going to give you either all those hair cells are going to give you an excitatory message or an inhibitory message when there's flow of fluid along that canal. So, in that sense, it's kind of hard to hide.
Ah, understood. Understood. Very helpful. So, just for anybody who memorized it as anterior canal, same as superior canal, so don't get confused. Unfortunately, many things in the vestibular world seem to have multiple names. I know the Menière Society is trying hard to get some unification there, but it's going to be a long road, I have a feeling. So, patients with dehiscence, which is that opening or thinning of the bone overlaying the superior semicircular canal may experience a variety of symptoms. So, one is not just dizziness or vertigo, but specifically can be pressure or sound induced. And we'll talk about why. Also, they can experience what they call hyperacusis, which is an increased sensitivity to everyday sounds, including internal body sounds, and pulsatile tinnitus may be experienced. And this is a perceived sound that is usually rhythmic and synchronized with heartbeat, because again, this kind of internal body sounds we might be hearing uh, kind of in the mix there. So, given that, we say, why? Why is this happening to me? That's patients ask me that a lot. So, unfortunately, from your article, at least with the diagnostic criteria, it appears that the cause is not officially known. There's some theories. So, I'm going to run through those, and I'll be interested in any kind of new updates you might have in this area. But one theory has to do with a congenital decreased bone development in that area. And so we'll call it a developmental issue, right? So little tiny embryos growing inside of a mom, and as the body gets put together, sometimes things get put together a little bit differently in one person versus the next. Um, and I always like to point to my own crooked pinkies. They have no relevance to my function, but here they are, born like that, right? So we have these little anatomical variations that can come up, and sometimes not so little anatomical variations, but in this case, it is a small area, so we'll call it little as far as the semicircular canal area. Another theory is that there maybe the bone is a little bit thin, but what really kind of crossed the line is if there's an initial secondary event, such as a head trauma, then that really is what caused that thinning to then turn into a dehiscence. And then a third theory would be possible increased bone turnover. So, the bone in our body can have building from osteoblasts and then being broken down by osteoclasts, which are very wonderfully named for me to remember. And so that bone reabsorption may be just kind of happening more in that area. So, any updates on those theories that you're aware of, Dr. Carey?
Yeah, look, we don't have the definitive answer. I strongly favor the congenital hypothesis, and maybe I can share a slide or two and explain why.
Sure.
So we have a unique temporal bone collection here, over 1,000 temporal bones. It's unique because of the way they were sectioned. They were sectioned vertically. Many of the temporal bone collections around the country were sectioned horizontally. And in fact, they were sectioned along the axis of the temporal bones so that you kind of get the superior canal in one cut almost. So we were able to look at the range of bone here. This is what we usually think of. There's aerated bone over the top of the superior canal, widely separating it from the middle cranial fossa. Here's a case of very thick bone, clearly high resistance to any transmission of pressure through there. Here's a case of thin bone, but intact. And here's a case where there's actually that that's probably just periosteum, but there's still dura over it. And I really want to emphasize that because I think that's key to a more nuanced understanding of this. Here's a case where there was genuinely missing bone over it, and it was just thin dura over, clearly mobile tissue here. So that's probably frank superior canal dehiscence. So in temporal bones, we find that, I'm just going to round this off and say um, dehiscent or thin bone in 1 to 2% of human beings. And that's actually pretty similar to what we see in high resolution CT scans. So I tell patients, there are 1 to 2% of us walking around all the time who probably were born with thin or missing bone over top of the superior canal. Not that many people are symptomatic. And I
Right.
think that has to do with impedance and the role of the dura here. So, after this was discovered, John Rosowski came up with this model of a third mobile window that we all perceived as this, a big hole here, and that allows flow through the superior canal when there's sound or pressure coming in at the oval window or round window. But that picture I don't think is right. I think it's really more, we have to think about the dura overlying this plate of bone here. And you saw that dura, I'll just bring it back up, in this slide is pretty thick. And if you've ever operated, the dura is like reinforced leather. It's really thick. So you could have an opening in bone, but have tight dura and have no transmission, no symptoms at all. And we see that a lot. I think the patients who come to see us have something like this, where the dura has been thinned out. For
Mm,
example, you get a head trauma, a shear stress, maybe thins that dura out a little bit, or you've got, a wave of pressure that comes through. First patient who ever saw Lloyd Minor was digging up a shrub and grabbed it to give the final pull and grunted. And, I think it
oh,
probably stretched that dura that previously was rigid and turned it into
yeah.
something more like that. Okay, I'll stop sharing.
No, that was great. And I just a side question that has been burning in my mind. I have many. So a mobile window, this is a term that is also kind of tossed around in reference to these third window syndromes. Am I understanding a mobile window to be simply an area that is not bony and it's either open or just thin membrane? Or what does that exactly mean?
Um, Helena, I think of it as it's all about impedance. It's all about impedance. So I I conceive of this, if you go back to your one of your early slides showing the labyrinth intact, right there, that was great. Or this one, right? So for us to hear normally, there should be one way in, sound comes in at the stapes, and one way out. It goes out at the round window, and everything else in that compartment has to be encased in a concrete wall rigid bone. This is the hardest bone in our body. And it has to be that way for us to keep hearing and balance separate functions inside this same fluid filled compartment. So if there's a soft spot anywhere in this system that has low impedance, you've got the opportunity for sound and pressure to flow somewhere it shouldn't be flowing. So superior canal dehiscence is an opening in the bone. Uh, Enlarged vestibular aqueduct is a native opening that should be there. It's just too wide and has low impedance, and it's allowing flow. Um, Even perilymphatic fistula, it's a weakening of the annular ligament around the stapes, or it's a defect in the round window membrane. Again, lowering the impedance to flow somewhere in that system. So now you have somewhere outside of the usual pathway, oval window to round window.
Got it. Uncontrolled traffic. All right. So um, that brings us to this slide, which is why third window. And your paper briefly mentions the idea that there are two normal windows, if you will, as you've referenced, I believe, already in speaking, the round window and the oval window is the other. And so those are our two windows we all should have, correct?
Yes,
Okay, good. So you want two, third, that's too many. That three's a crowd. I gotcha. All
that's
right.
right.
All right. So, it is, and you've mentioned this just now, so I'm just going to reinforce it because I have had patients have worries, right? Oh, I thought maybe there was a problem, and they did check, and they saw there was thinning, and the question can be, and I found a nice article on the kind of the challenge of vestibular migraine coexisting with semicircular
Yeah,
canal dehiscence of the superior canal, because as far as symptoms, sometimes there's overlapping causes. Sometimes there's what seems like the cause, but he's not really the cause. And then there have this other cause, right? So,
yeah,
I certainly have patients who have BPPV and vestibular migraine or what have you, right? So we see these patients with, maybe a couple different contenders. So it is good to note that just because there is a thinning, that does not mean that that's causing dizziness symptoms. Would you concur with that?
absolutely, absolutely. And so, with any new diagnosis, you go through this life cycle. So the first problem you have is you got to get the word out. People haven't heard of it, right? Your colleagues aren't aware of it. Patients aren't aware of it. So there was a strong effort. We need to get people to understand that if you hear your voice, you hear your pulse, you get vertigo from coughing, straining, sneezing, and loud sound, you need to look for superior canal dehiscence. Okay, we got through that phase. Now we're in the second phase, which is actually people are doing CT scans for the wrong reasons. And one of the problems is that there are many ways to do a CT scan. And the scan you're showing here, it's a good scan, but it's not perfect. And
Mhm.
so if you were if you were at the workstation and you zoomed in, you would see some fuzziness to the bone edges. That reflects a lot of factors. It reflects some physics factors of how the scan was done, and it reflects a lot of post processing factors. So you don't get an image out when you run a CT scan. You get a bunch of three-dimensional data about the radio density of little bits of tissue. And then you have to do some processing to create an image out of it. Well, you have to make some decisions in that. One of the decisions is, do you want to see all the tissues like muscle and fat and bone? In which case, you're not going to get a lot of detail about the bone. You're actually going to wash out a lot of detail about the bone. Uh, and so, if you're a busy radiology practice, you don't want to miss tumors. So, you may set your algorithm, your filter, to
Mm.
let you look at soft tissues a little more. Well, guess what? That's a perfect way to make thin bone melt away in your image. Likewise, if the images are thick, you're averaging a large thickness of tissue, it makes thin bone disappear. So patients come to see me all the time. They've been told, oh, you definitely have superior canal dehiscence. Go see them and get this surgery done. And I say, wait a minute. We wrote this paper that we're talking about at Journal Club today, really emphasizing it's not just CT alone. You have to have you have to have historical features of it. You have to have physiologic features of it, either in the hearing testing or vestibular testing, as well as a good CT scan. And we never make the diagnosis based on CT alone because I think there are a lot of people who have true openings in the bone but aren't transmitting pressure because the dura is still high impedance.
Got it. Very interesting. Yes, so let's talk about this criteria. Everybody pay attention. This slide's important. Um, so we want to know what's going on. We're trying to help sort out diagnosis. Should we treat? Should we not treat? We'll talk about treatment later. But I think what's important about this criteria, in my opinion, particularly as a non-ENT, non-surgeon, right? I'm a physical therapist, but I have patients walking in my door with very vague dizziness and giddiness type diagnoses on their scripts sometimes. And so I'm trying to do what I can to help as far as kind of get closer to sorting out diagnosis, because of course that could impact, with the correct treatment for the patient, right? So I think most clinicians can relate to this feeling of like, I have some responsibility, is how I see it. And so we're looking for at least one of the following. And I think sometimes people look at like, oh, you have to have everything on here. Well, no, that's not the way it's written, right?
No, no. One of the crazy things about impedance, you notice I keep saying that instead of resistance. If you go back to your physics 101, impedance is frequency dependent. So depending on the frequency of the stimulus, you may get a different response.
Mm-hmm.
So you put your video goggles on someone and you put headphones on them and you play a 100 dB tone very briefly. You may get nothing at 250 hertz, at 500 hertz, at 750 hertz. And then at 1000 hertz, their eyes will dance like crazy. And at 2000, it stops, and above, it stops. It can be very frequency dependent. Another patient won't have any nice nystagmus and they'll just have auditory symptoms.
Right.
So impedance is kind of flaky. It's kind of nonlinear. It's frequency dependent. And um, that's why when we wrote these criteria, we said, this is not just a vestibular disorder. This is a hearing disorder.
Right.
And the problem is some of these patients, they have very hard uh, diagnostic findings for on the audiogram, but they don't have any vestibular findings, and yet they feel dizzy.
Yeah. Yeah. And I have a patient, I'll be showing you a video of her later, um, where she had been seen and they had felt that she did not have this condition, that they had ruled that out, with the hearing test not having any findings of note. And yet, um, I was able to induce a particular nystagmus that, like I said, I'll show you guys shortly. With my vibration induced nystagmus test, it's a quick screen on my end, which mostly I'm looking for old hypofunctions. That's why I like to do it, because then that's the side I think they're going to have BPPV on. That's like my number one reason to do it. Or maybe it gives me a hint as to why someone has developed a persistent postural perceptual dizziness if they have signs of an old hypofunction that I can't pick up on my head impulse test, which I don't have a video head impulse test or anything. So I'm just doing it bedside. And so she did not fit the kind of the hearing part, and so that's why she's been told she didn't have it. But yet she did have, of these, for my example patient, she had a pressure induced sensation of dizziness for sure. She had the nystagmus when I did the vibration induced, which I consider to be in the second box there. And then she demanded getting the CT. And so I think her primary wrote for it or something. And uh, that did show thinning. So, and I thought I'd done a pretty good job, and so had the ENT. Granted, they had done their part, I would argue, looking for bilateral loss or anything else. And for what I can do, looking for BPV, she did not fit vestibular migraine criteria, which is what they were kind of trying to point it towards. But I'm like, this doesn't, if you've seen so many patients, Dr. Carey, right? Like, it's the
Right,
patterns. Like, you're like, all right, this doesn't, it's not feeling like vestibular migraine to me. Like, I don't know,
right,
something's not right.
right.
So I think that's where, the more practice you have, the more experience you have, the more training and mentorship you have to try to look at these criteria and to say, okay, yes, are we checking boxes here? That's why I like my little yes over there. Like, do we
Yeah,
have one of each of these for real? Right?
yeah. Let me give a couple of thoughts, if I can, about the first box for history. So, really important to me when patients say, "Oh, I get dizzy with certain sounds or certain pressure changes," is this the second part of those statements, the timing relative to the stimulus. So, I'll say to a patient, "Okay, when patients tell me that they are getting dizzy from loud sound, there are usually two types of complaints. One is I hear a particular loud sound, like a fire truck going by, and I see the world move for a few seconds, and when the fire truck is gone, the movement stops, and a couple of minutes later, I'm back to the way I was. The second flavor is I go into a noisy bar and I'm immediately kind of thrown off balance. And the longer I stay, the dizzier I get. And I leave that bar, I'm dizzy the rest of the night.
Yes.
Okay. The first one is SCD, the second one is probably migraine.
100%. Yeah.
They're not completely separate. But, similarly, on number three, the patient says, oh, pressure changes make me dizzy. you know, if they say, having a bowel movement, and all of a sudden I see the picture on the bathroom wall jump, and I finish my business and I get off and I'm okay. Versus, oh yeah, if I get on a flight and it's a lot of pressure changes, my head feels full, my ears feel full. I never have spinning vertigo, but I just feel terribly dizzy, and I'm ruined for 2 days after that. The first one's SCD, and the second one's probably migraine.
Yep. Exactly. That's the stories. You keep starting to hear the patterns, and there's always exceptions. But yeah, no, I totally agree.
Yeah.
Yes. But of course, and I wouldn't expect a patient to know, right? Like that's the thing. So
Why
they're
would they
coming in,
know?
they're like,
Right.
right? Why, how would they know, right? Unless they really read everything that we ever posted. Yeah. So really trying to help on our end as clinicians to do this kind of what fits the pattern and what are we getting with our tests and putting both of those things together, right? Um,
Yeah, and the hard
so
part is, and I know you see this too, is the
yeah.
patients who have both, right?
Yes.
They
Yes.
they've got superior canal dehiscence, which is like being on a roller coaster every day, and it triggers migraine. And
Right.
so then they'll have
Right.
features of both, and you have to kind of disentangle that.
Yes. Yes. The multi-layered onions are definitely the most challenging for sure. Um, all right, so we're going to talk about possible symptoms briefly, just because I want to get into a little more detail for folks who, as a clinician in particular, since that's where we gear these journal codes primarily towards, what you could be listening for. But they're just, again, you're trying to put all the clues together. And for me, for almost every diagnosis, one piece of information is not enough, right? We have to kind of look at the big picture of symptoms as well as the big picture of our physical exam and testing that we can do. So, one possible symptom is this term autophony, hearing your own voice loudly or distorted in an affected ear, which could be bilateral or could be simply one side. Um, and then perceiving one's own body sounds. Cool word I never saw before that I'm not going to try to pronounce. That means digestive sounds. Had to look that one up from the
Berberigme.
article. I love when I have to look up a word. I really do. So hearing your own eye movements or blinking, hearing, your joints in a really loud way that's like feels internal, as I understand it from patients that I've spoken with. And so, I've had patients tell me that they felt like they were crazy because you're experiencing this and they might not have shared it because of that. Is that something you have also observed?
Oh yeah, there's a great video you can find on YouTube, ABC 2020, the series they used to do. Um, they may have found the index patient with superior canal dehiscence. So he's a French horn player who tells his story that not only did blowing his horn make him tilt, but he could hear his eye movements, and he realized it once he was uh, on a trip and he was laying in the hotel bed reading, and he picked up the phone and called the desk and said, "There's a mouse in the wall. I hear
Oh
this
no.
scratching sound." And so they came and they, scoured the room. Like, sir, there's a mouse in here. And so when he went back to bed and tried to read again, he realized, oh, it's my eyeballs I'm
This
hearing.
is time locked with what I'm reading. Yeah.
Exactly.
Yeah. And yet, I will caution everyone that autophony is not necessary for diagnosis. So, just because a patient does not describe this particular symptom doesn't mean they don't have superior semicircular canal dehiscence, correct?
Right. Again, it's all about impedance, and is that pathway in that particular patient with that particular dehiscence, is that pathway actually affecting the hearing in a way that distorts the hearing? Um,
Exactly. Perfect. All
by the
right.
way, if you want to
Yeah,
know
go
what
ahead.
it sounds like, a patient told me to get one of these. This is called the tubaloo. This is to
Oh,
teach your kid what inside voice should sound like. So they said this is what it sounds like to have superior canal dehiscence. Um, it's your voice is loud, but it's also distorted. It's like a broken
mm-hmm.
speaker. The other important tool that I encourage you to get, um, and it's amazingly cheap, a 512 hertz tuning fork.
Oh, yes. Yes.
Putting that on the head, doing the Weber on the head, or even better on the teeth, um, it, it's pretty revealing, and almost always it's as sensitive as the audiogram for me in finding bone conduction hyperacusis.
Cool. Okay. Love it. Love the simple screening tools, especially because, at least for me as a physiotherapist, if I'm suspicious, of course I'm going to refer, right? Like it's not my job to order a CT scan with the particular oblique cuts, and I know about it, but it's not my job, right? So when I work as a team, that's how I see it.
Yep.
And if they haven't had a hearing test at all, then I'm suggesting that and so forth, right? So very good to have some screening tools to help bolster my reason to send someone who is probably going to have to wait several months, uh, potentially, to see the very popular ENTs. So, yeah, awesome. All right, so another possible symptom that has been described is the Tullio phenomenon. So, this is a sound induced vertigo. And again, you've mentioned this kind of time locked idea. So, there's a particular sound, and again, it might have to hit a particular frequency for a particular person, and that can induce a sense of vertigo and or a sense of, you kind of mentioned the world bouncing, kind of this. That's how we describe oscillopsia, the fancy word for kind of like double vision or blurred vision, or it's when the eyes are actually having a nystagmus typically, um, and such that that patient might perceive that. And patients have certainly told me, regardless of the cause of their nystagmus, sometimes they will just more feel their eyes moving than anything else, because we kind of
Yep.
forget, but like there are essentially proprioception, in your eye muscles and so forth, right?
Yeah. It's one of the fascinating things about this is that I can see two patients back to back, and they may have 500 hertz induced nystagmus in the plane of the superior canal, and one of them will scream, like, "This is horrifying. This is terribly dizzy. The world is, falling apart." The other one will be like, "Yeah, I feel my eyes move, but I wouldn't call it vertigo."
Totally. The breadth of personal experience on these various symptoms is remarkable. I'm right with you there. But we care about all the patients, but particularly, of course, the ones that are perceiving it in a more difficult manner. So I'm going to show you, everyone out there, a really quick video pulled from YouTube. Thank you to Dr. Scott Sanders, who put up some great ones. So this is going to show vertigo in the plane of the now. Definitely getting that bit of the downbeat portional, would you say?
Right. Yeah. So you'll notice there was both a vertical component there and a torsional component. So the eye moves in the plane of that canal, and there was a slow phase going up and a quick phase going down. Um, if I can, I'll put on my silly hat and demonstrate the three-dimensional of nystagmus. 1 second. The giant eyeball showing up,
Love it.
and the crazy hat. Now let me adjust my camera. Tell me if this is fully visible. Is that showing up?
Love it. Yes.
All right, so this is you just showed this is the left eye, and that patient had a left. So you're presenting sound to the left ear, right? Correct.
Mm-hmm.
Okay, so if that patient has an opening in the top of the left superior canal and sound going in is flowing up that pathway, that means the endolymph is moving that way, which is normally caused by the head moving down and to the left. So the eye is going to respond as if the head is going down and to the left. The eyes are going to go up and to the right, slow phase, and quick phase is going to be down and to the left. So it's going to be this. Now, what I ask patients to do is the eyeball showing up there? I ask patients to shift their gaze. So I'll put the eye in the plane of the affected canal, and then you'll see it's purely vertical.
Mm-hmm.
And then look orthogonal to that plane, and it's going to look purely torsional. Does that make sense?
Yes, definitely. Yeah, and I
And
think it's a good reminder to everyone that generally peripheral nystagmus, regardless of cause, whether it's BPPV or dehiscence or hypofunction, will follow some of these rules for gaze that help us to kind of tease out components of direction, right?
yeah, no, I use that trick all the time, and if that works, it's diagnostic. There's nothing else that can give you that such specific canal plane nystagmus.
Right, right. All right, perfect. So that brings us to another possible, might get both, might just have one, pressure-induced. But again, looking for possible nystagmus, patient might be feeling vertigo and or experiencing this kind of oscillopsia type sensation, if you will. And this can be with what we have called a Valsalva historically, which is some sort of pressure, internal pressure created by holding your breath, coughing, straining, sneezing. So you can certainly bedside, as we say, without too much equipment, ask the patient to pinch the nose closed and blow, or to bear down as if they're lifting a heavy item. Or some people will try using what they call the tragus test, which is applying pressure at the ear canal, which you can do informally by putting pressure just with a finger. There is a way to do it with an otoscope, I believe. Um,
I'll
that,
tell you what, I
yeah, go
no,
ahead.
I found nothing is as reliable as me just putting a glove on my finger and getting it wet to get a good seal, because you'll actually
Mm,
feel if you have a good seal or not.
okay. Interesting. Good tip. Everybody watching that? Good tip. Get that. Note that. Tips from Dr. Carey. I love it. All right. So
And,
yes, so we can
and
look
if that
for,
fails, just ask the patient to do it because they know what causes
yeah,
their symptoms.
yeah. No, they can usually, no, you're right. Patients can be very helpful that way, actually. And in the article, it notes that symptoms may occur with application of pressure or at its release. So it's good to remember that as well. So I do have a quick video so folks can get a sense of this is a Valsalva induced uh, nystagmus of sorts,
Oh yeah, look at
and
that.
getting that. Yeah, you like that, right? That's nice torsional. Yeah.
This is a glottic valsalva. They're holding their breath, not pinching their nose.
Mhm. Mhm. Yep. Yep. So it just gives us again that type of nystagmus that's not huge, right? It's not the sometimes with BBV we'll get this really big, right, kind of brisk nystagmus, if you will. This can be more subtle. Would you agree?
Yes. And again, with both the valsalvas and the external auditory canal pressure, it's often on release because I just think there's a higher velocity of flow because there's a sudden
Hmm.
pressure change. So
Got it.
oftentimes, when I'm compressing, the patient won't say, "Oh, it's nothing," and then you pop out, and it's a very prominent stimulus.
Awesome. All right. So we've talked about what the nystagmus can look like. Ideally, we are observing it without visual fixation. So for folks who aren't familiar, that's in the dark or without the ability for the patient to fix their gaze on anything, which would otherwise suppress often, especially smaller, if you will, kind of less brisk nystagmus, depending on the response. So you don't want to miss that. So we're trying to use something. Some people use the original thickened lens Frenzels. Some people are using infrared video goggles, something like that. So I understand that sometimes the nystagmus will not be downbeat torsional. It might be upbeat. True?
Right. So it depends on the direction of flow that you're causing. So generally, well, I'll put the hat back on. Um, let's go with left superior canal dehiscence again. So hole up here. Uh, if I pinch my nose and blow, I'm sending pressure up the eustachian tube, pushing in the stapes, and I'm sending flow that way. So that's the same as the normal excitatory stimulus. So you should see a slow phase up, down beating. For glottic valsalva, there I'm increasing intracranial pressure. The fluid flow
Mm,
is down this way. So it's usually opposite. It'll usually be slow phase down, quick phase up. Um,
right.
Sound can actually go either way, but it's usually excitatory. So it'll be slow phase up, quick phase down.
And someone told me once, I feel like that it could depend on where the dehiscence exactly is or how big it is. Does that seem possible?
Um, I haven't found it depends so much on location or size.
Okay.
That affects other things. When we did this in an experimental model and created an opening and systematically, recorded, we could record from vestibular nerve fibers. The interesting thing is the sound evoked response can reverse.
Mm,
And this has to do with the complicated physics of a tubular system that has wonky impedance. But Rick Rabbit has done a lot of nice work on there. You actually get not only some standing waves that form, but there's a bulk flow phenomenon that occurs due to a pumping effect that the hydrodynamics physicists have described in these systems. So it can go one way or the other. Um,
got it.
Usually, I will say 95% of the time, the sound evoked nystagmus will be excitatory. So it'll be
Got it.
slow phase up, quick phase down. And the torsional, so it'll be this. So the torsion will go slow phase ipsilateral, ear, quick phase contralateral.
Got it. Right. So, and for me as a screening person, I'm just saying, am I suspicious? Is it
Yeah,
following a pattern? Is it responding to this input in a pretty consistent way? And that at
yeah.
least gives me enough to stand on that I feel like reasonable to refer. And that's, not that everyone watching here is a physio. For those who are, kind of that would be your next step. That's where my mind goes in case that helps anybody else. So I'm going to show you the video of my patient who they thought maybe had vestibular migraine because she did not have the classic hearing symptom findings. But she was getting symptoms kind of more with exertion. They were like, oh, it's just vestibular migraine. But like, she was not light sensitive, none of that stuff. You know what I'm saying? I was like, I don't know. And so I was doing my vibration-induced nystagmus test, like I said. All right, here we go. And what I see for her, when I get the vibration on her vertex, right, that kind of top of the head in a moment here, is a pretty reasonably upbeat. Um, and I didn't get a lot of torsion, but I also didn't make her gaze, which I probably should have in retrospect. But be that as it may, I got it again when I was on the right mastoid. So given kind of her reports, and I felt like she was checking the boxes enough to warrant the CT at least, and what the result of that CT was a bilateral severe thinning. Um, and I don't know if that bilateral influences that there was a little bit less torsion to see either. That's a question for you.
Yeah, I've actually seen that before. If you get somebody who's got symmetric, the impedances are the same, you're going to get flow in both of them. So the vertical component will add and the torsional component will cancel out. So they can get a purely vertical nystagmus from a midline stimulation. Yep.
There, there you go. So, again, for me, just looking for clues. And honestly, I don't know whether she'll end up, the right word is needing surgery or not. But the important thing to her was, because she's a very active person, hiking, etc. She wanted an answer. And you know how patients sometimes they just need to know why. And then if it's like, well, not really worth the surgery or something, at least they feel like they understand. And I feel like that can completely change how much they even notice symptoms, like how much they worry about them for sure. And knowing that it's not something serious, which I understand why they would not want that to be missed, right? They don't want something serious to be missed. And they want to feel like they have a clear answer that makes sense.
Oh, I completely agree. And I tell patients, um, this is not just in your head. Well, actually, it is in your head, but in a very different way. It's a very physical thing. It's a mechanical issue. And I tell them, okay, now that we know what it is, this is not a life-threatening condition. It's not a degenerative condition.
Right.
We have no evidence that this causes people to lose hearing and balance function over time. The way I describe it is, unless they have auto plugging, which we can talk about, I say, look, your semicircular canal does its day job. It senses head movement and it creates an equal and opposite eye movement. I can see that on your head impulse test. The problem is that it's moonlighting. It's sensing sound and pressure and giving you, terrible information about, that your head is moving when it's not. And so that's a life limiting condition. And you've got to decide, is this bad enough that I want a surgery to plug my canal, which is going to cause some very specific geometric vestibular hypofunction, but that responds very well to vestibular physical therapy. If it's bilateral, yeah, that's a little more challenging. But almost I would say all the patients who've had bilateral superior canal plugging, if they do it for the right reason, they're happy they did it. But physical therapy after the second side takes a lot longer.
Sure. Less to work with. I gotcha. Um, yeah. So, I mean, I think it's maybe a less understood thing that it could be for clinicians and maybe patients too. Like, you know, sometimes we're not going to get an answer. That's life, unfortunately. But most of the time, if we can find an answer, and then we can say what's the right next step, right? What's the right next step for you, and what makes sense, and it can be case by case. But I think there's no question that patients, generally, yeah, they want answers, and that's fair. So, I was happy in that case to be of help to that patient on their next step. And they're still gonna, meet with an ENT and see if surgery would be warranted in their particular case. What I told them is definitely not my scope, but um, they just already feel a lot better that they understand. So.
Yeah,
All right. So you mentioned already having that tuning fork available. I'm giving everyone who's not familiar a drawing, excuse me, thank you, Netter, of the Weber test, which is where they take a specific hertz, again, a specific frequency tuning fork, um, and place that then correct on the middle front of the head.
hmm
And then essentially you're looking to provoke a potential um, a stronger sound, I guess, like a asymmetry sound, like, I definitely hear it way stronger on the left or something like that. Is that correct?
right. So the idea here is, with that abnormal opening in the bone, you not only have low impedance for the sound that's going through the endolymph and perilymph to escape, so you lose some hearing for air conducted sound. There's also, it works in the opposite direction. Sound that's going through bone gets into the inner ear better than normal. So what we'll see on their audiogram is their air conduction thresholds are worse than normal. Their bone conduction thresholds are better than normal. So we see these air bone gaps. It's predominantly low frequency, um, and we'll often see negative bone conduction. The negative bone conduction assumes they don't have inner ear damage. That's a pretty conservative criterion, and when you read the Barani Society paper, we put that in there to really be very solid. But that's a little bit of a problem for the older patient or the patient who has
Hmm.
another hearing problem. They may not have negative bone conduction thresholds. But if
Right.
they have one-sided dehiscence, um, Weber lateralizing to that side, that they hear that bone conduction better in the ear that has the dehiscence is a pretty darn reliable thing.
But not as
Putting
much for a bilateral then, right?
uh, correct. Now, they it's probably asymmetric and they'll often
Mm,
lateralize to one side.
got it.
Um, Find the thinnest spot, with the least fat over it. You can use the hairline, you can use vertex, you can use the nasion, the bony part of the nose here. Honestly, the best thing is put it on their teeth. Put it in a glove and stick it on their teeth. The other reason I do that is like they have no preconceived notion. They're so shocked that you're going to put a tuning fork in their mouth.
Yeah.
They're not trying to guess like what answer am I supposed to give. They're just going to tell you.
No, no known answer unless they're really good Googlers in advance. All right, gotcha. All right, cool. So very helpful information as we're trying to continue to, sort out what's happening with our patients here. We talked a little bit about this already. Hearing loss may or may not be present, might be mixed, conductive versus what they call sensorineural, which is more kind of in the inner ear itself structurally, I guess, or the nerve. It could be a mixed bag, right? So it's not like the hearing findings are the end all be all for this diagnosis. It's one more piece to the puzzle, as far as I can tell.
Yeah, super important piece of the puzzle. I would say the majority of patients, when properly tested with an audiogram by a careful audiologist, you will find low frequency air-bone gaps and usually bone conduction hyperacusis, but not always. And that's not because there's anything wrong with the testing. It's because of impedance, and
Right.
impedance creates weird flows. And those frequencies that we test, they may not be affected. You know what may be bothering them? It may be a 10 hertz flow. So some of these patients, they'll hesitate to tell you, but they hear building sounds. They sit down in your waiting room chair and they can hear the air mover on the roof of the building. They can hear that 10 hertz vibration or they sense it because the cochlea is really not very sensitive to stuff that low frequency in human beings. Um, but their inner ear, their semicircular canal, their vestibular system is transponding that crazy low frequency stimulus, and they know something is wrong. So just because it doesn't show up on the frequencies we test on the audiogram doesn't mean there isn't something there. Craziest
Good
symptom a
point.
patient ever told me. They said, "I sit on the pew in church and I hear everyone else's bowels."
Yeah, not ideal. So not a superpower I want to have. Okay. Uh, other testing we might do to help give us clues, but by itself, not end all be all. One is VEMP, right? Our vestibular evoked myogenic potential. There's cervical and ocular. This is not detailed how to do that test for the sake of brevity, but understand it's a known vestibular test. It tests a very cool pathways for atrial and saccule, but then there's lots of connections also. So it's not just looking at those otolith organs per se. And there's some specific findings that you may find. But again, if you don't find them, that doesn't mean they don't have it. And if you do find them, there might be another cause of that finding. Is that correct?
Yeah, yeah. The way I think about VEMPs is we didn't evolve to have VEMPs, right? VEMPs are some crazy vestigial tiny reflex because we happen to have our balance organs and our hearing organs inside the same bony capsule. So all of us have a little bit of bleed over of high intensity sound energy out of the cochlea into the vestibular system. And so we take advantage of that. We detect what the saccule senses with cervical VEMS because our gravity sensor controls vestibulocholic reflexes, and we sense the bleed over of utricular information going to our eyeballs because we're we share that evolution with lateral-eyed animals that needed to know when they tilted, one eye needs to go down and the other eye needs to go up. So we're just harnessing this crazy vestigial reflex. And the simple answer is, if you've got a low impedance pathway that's letting more sound get into the vestibular part of the ear, these things are going to be enhanced in some way. Either the amplitude is going to be bigger, or the threshold is going to be lower, or it's going to be present at a frequency it's not normally present. So like 4,000 hertz, most people don't have measurable VEMPs unless you're doing really careful research studies. So if somebody's got a brisk 4,000 hertz VEMP, that's the screening test for some labs.
Got it. Excellent. All right. Some people are trying to look at the video hit impulse test, but it seems to me from the literature that I could pull up, there's kind of varying responses you might get. The gain may be impacted, and there's theories as to why. I'm sure you're familiar with this literature. Any input you want to add, or just kind of not your top test for this particular condition?
No, so I would emphasize, don't expect people to have superior canal hypofunction in the majority of cases. It's that's a phenomenon we call auto plugging. So if the dehiscence is big enough, if there's enough length missing, the dura can herniate down and compress the membranous labrum. So those people will have actually some reduction of function, maybe a gain reduction of 0.3 to 0.5 on their VHIT test. By the way, those are the most ideal patients for me to operate on because they already have a plug. You know, they're already adapted to superior canal hypofunction. The problem is their plug is not rigid, so it's still transmitting sound and pressure in a way it shouldn't.
Got it. Good tip. All right. And then, of course, imaging. This is what would be considered the gold standard, the high resolution CT. There's discussion in the criteria article about kind of the ways that you would want to section the pictures, as I think of it, to try to get the correct angles. You were talking earlier about this as well, and how the resolution should be a particular amount. Is there a certain way that you are writing how you want your scans done? Are other doctors doing it that way? How does that work?
Yeah, so this is an ever moving target as CT technology changes. Um, Most CT scanners out in practice today are multi-detector CTs. So you lay on a table and a photon emitting source goes around a circle and a detector goes around the circle. And in fact, there's usually multiple detectors. So it'll be 16, 32, 64 operating at once, because what the companies are really going after is cardiac CT, the ability to image the heart. So they want to get a bunch of images in a very short amount of time. Those are pretty good. And with those, it really doesn't matter the plane, the head is
Mm,
tilted or anything. You don't have to put the plane. Used to be you had to put the head in some funny plane to get a coronal versus axial image. No, that's not so much the issue anymore. Um, the issue is now more with uh, just the limitations of standard CT technology, which is actually very temperature dependent and really subject to vibration artifacts. Enter this. We just went through the next phase was flat panel CT, where you've got it's more like what you get when you go to the dentist and you get a Panorex done. That actually improved the resolution a lot, and we've written some papers on that. The latest kid on the block is photon counting CT. So photon counting CT is a fundamentally different thing that I won't try to explain because I don't even understand it. It depends on some quantum properties. But the beautiful thing is it takes temperature out of the equation. It doesn't
mm,
depend. It's not subject to heat abnormalities, and it gives us super good resolution. So when we have we often get these, is this, isn't it CT? I'll send them downstairs to get a photon counting CT. and that usually resolves it. Not universally available, very expensive units. Most patients don't need that, but when we really have a residual question, we'll send them for that.
Good. And I think it's important, not that every person demand every level of test, but that we always are balancing results of a test with the other features, right? CT was
Yeah.
not the only, again, not the only definitive thing on our criteria. So we do want to be looking at the big picture and doing that due diligence if it's continues to be suspicious, right?
Yeah, and Helena, one last point about that. Almost all the CTs you're going to get in practice today are sensitive. The problem is they may not be specific. So if somebody has a dehiscence in their superior canal or thin bone, uh, uh, almost always a temporal bone CT is not going to miss that. The problem is it may overcall it. So
Mm,
you don't need to worry about sensitivity of CT. You need to worry about
got it.
specificity. It could suggest there's a dehiscence there when there's not. But
Understood.
that's when we go to the physiologic testing.
Makes sense. All right, so I just put this up again for everybody because that's the main crux of this article. So hopefully, like through all the details we just went through, this is kind of our big picture always, kind of looking at this checklist of sorts and saying, does this fit? And then some differential diagnosis. So I made my own little Venn diagrams, and I hope you agree. Someone might say, well, how do I know if someone might have semicircular canal dehiscence, or is it perilymphatic fistula? Like, how would I guess that as like particularly a bedside, we'll say physio? I'm just trying to kind of use my limited testing. I don't have, we're not to the point of getting that specialized CT or MRI at this point, right? So I'm listening for the common report is going to be possibly sound and or pressure induced vertigo or nystagmus, and maybe oscillopsia report, something like that. But differences that I'm listening for is my understanding is that it's more common for a perilymphatic fistula to happen in cases of trauma. Now, trauma can be head trauma. Trauma can be barotrauma, which is like a pressure trauma. Like maybe I came up too fast from scuba diving. Is that correct?
Yep.
Okay.
Yep.
I've heard of it from birth, labor, like trying to
Yep.
push the baby. Okay. Right. So trauma sounds like it's like you got hurt, but it can be just like a big pressure situation, right?
Yes, that's right. And it could also be pressure to the ear. So a blast, um,
Mm,
even something as simple as somebody tried a little too hard to clean their wax and pop the ear.
mm.
Yeah.
Yes, get those Q-tips out, people. All right. Um, then resolution of symptoms after treatment, which is kind of like a backwards way to identify your condition. But there's definitely some stand apart findings that you, as an ENT, would use to probably differentiate that perilymphatic fistula from a semicircular canal dehiscence, right? So it's good to know that there are conditions that can kind of have these common things, but also can have some standalone type presentations.
Yeah.
And that brings us to our favorite vestibular migraine, which you've already given us some great examples of how you might hear a different history. For this diagram, went a little bit more by the criteria. So vestibular migraine does have some excellent criteria that it can be definite or probable. So it doesn't have to be so specific, but we are looking for patterns of light sensitivity, maybe sound sensitivity, although sound sensitivity is a little mixed because you might hear something that sounds like that for semicircular canal dehiscence, right? Um, People who are describing a family history might be helpful, although I've certainly had patients where they're the first person that they know of in their family with vestibular migraine, right? Or any migraine type, I guess. They usually are having episodes, although they often feel crappy between their episodes. Yeah.
Yes. Yep.
So that's why the episode thing is not as helpful as you think it would be. Um, and they'll maybe have like some headache report, but it's not always the major complaint, I would say.
Yeah, it's very often the case they'll say, "Oh, doc, I used to get migraine headaches. I don't get those anymore since I went through menopause or I had hysterectomy or I retired, a number of stimuli got removed. And they say, I don't get headaches. I just have this weird kind of fullness in my head and my ears, but I feel really dizzy and I'm really motion sensitive.
Yes. Right.
The things I really look for, light sensitivity, visual motion sensitivity.
Yeah.
They're still, but seeing things move make them just as dizzy as moving their head. Superior canal dehiscence does not do that.
Agreed. Perfect. And last but not least, good old Meniere's disease. Had to put that in there. That was in the article mentioned as well. Um, Hearing test results somewhat different. Yes.
Yeah, it should be a sensory neural hearing loss in that ear. So your Weber tuning fork, that 512 hertz tuning fork, should be heard in the opposite ear, and the audiogram should show the bone conduction thresholds are really low, depressed, meaning worse uh, than they should be, and they're going to be equal to the ear conduction threshold. So it's a sensory neural hearing loss.
Got it. Got it. And typically episodic. I would say that's a stronger pattern in my folks that I've had them come through my doors with
Yes.
pretty clear Meniere's. They have these pretty tough episodes that are pretty defined time frames of minutes to hours of some mix of vertigo and hearing symptoms, tinnitus, whatever. Um, People used to really fixate on the fullness of the ear, but I don't find that's a necessary report.
No, but it's a really helpful one. I mean,
Yeah,
patients
yeah,
should be able to localize their symptoms. Oh, yeah, it's definitely this ear. I feel fullness. I feel tinnitus. I feel the hearing change.
sure, definitely. All right, cool. Last but not least, you have a couple minutes left here. Treatment. So this is your area, not mine. I pulled this from the article. So we have some surgical options out there. I imagine that's always evolving as you all are improving your techniques.
Yeah. So, why do we choose middle fossa versus transmastoid? I do both. Predominantly middle fossa, probably 85% of my cases. The reason is you see it. You're looking down right on it. You've got a confirmation of the diagnosis. Measuring the actual microscopic opening has been really helpful in our studies for trying to come up with these correlations. You, I not only plug it, but I also resurface it. So you get a belt and suspenders repair. If the plug fails, the resurfacing helps. In transmastoid, then the advantage is we don't have brain retraction. We're not in the middle fossa, so fewer risks, but we don't see the dehiscence directly. It's pointing away from us. So we have to open the canal, bookended, fore and aft of where that dehiscence is, and rigidly plug there.
Got it.
And if you have a minute, I'll show a quick video of surgery if you want to see what a dehiscence really looks like.
Sure. Yeah. Why don't you pull that up? And then I'm going to ask, you kind of alluded to this, but your decision point for surgery is pretty much symptom based. Yes?
Right. So you got to meet the diagnostic criteria. You have to have it.
Check.
And you have to tell me that if you also have vestibular migraine or triple PD, because this can trigger those things, we're going to take those to the mat medically. We're going to take those to the mat with your therapy. And when that's done, you come back to me and you say, okay, these things got better, but it I didn't get any improvement in hearing my voice or hearing my pulse or the world bouncing when my child screams. Then it's appropriate to do surgery.
Right. And it has to be essentially, yeah, like not just mildly, like occasionally annoying, right? It needs to be like, yeah, worth the risk of surgery, right? Life interrupting
Yeah,
is how I think of it.
yeah, and worth the risk of some vestibular hypofunction that for which you're going to have to do physical therapy, and it might limit some of your activities down the road that could be dangerous.
Got it.
All right, let me do a quick. This is very short. So when we get this exposed, we see this trough opening here. Come back to the very beginning. You see it there, and we keep it wet. We don't want to lose the perilymph from the inner ear. This is some fascia sliding in under that thin bone. It compresses the membranous duct. We're going to slide that in both sides to get a watertight seal, fore and aft. There's some dry fascia to really hold it in there. That's going to expand. Now you see there's a plug here that has completely blocked off the perilymph and endolymph flow there. Here's a plug going in the posterior side, and I'll jump forward. Then we're going to push bone dust in there in both directions to that's what gives us the really high impedance. We even cork it with plugs of bone because we're trying to restore this super high impedance on both sides. We layer bone dust over it, and finally, we're going to put bone cement on top of this. This is a calcium hydroxy, it's a hydroxyapatite calcium phosphate cement that really achieves the same matrix as bone, and then we put a layer of fascia on and close up. So that's what that looks like.
Got it. Yeah, and it's good to know as a non-surgeon, kind of what's happening on the inside, and of course the expectations, which we're going to get to here on outcomes. So outcomes are awesome for the good surgeons out there like you, for sure, and really helping to address these patients, symptom issues as far as hearing their own voice, or even getting off balance, and vertigo type symptoms. Because the reality is if I have a patient come to me and they have a significant balance issue every time they hear a loud sound, I can teach them safety strategy, but I can't make that go away, right? Like there's no amount of balance training that's going to make that sense of suddenly feeling those symptoms go away because of the mechanical cause, right?
That's right. There you can train some avoidance things, and you can certainly help them with their core strength and their reaction time, and so they
Right.
don't fall, and tell them activities to avoid. But you know, at some point, it's such a life limiting condition, it makes sense to just fix it.
Right. Right. And it's a good thing, we're going to talk a little more about kind of the role, the partnership role. I like to think of it with the ENT and audiology world and vestibular rehab, because, we can hopefully support the patient in compatible ways. So, according to what was in the article, patients primarily with hearing type symptoms are have the highest likelihood of postoperative improvements. That's good to know. But then on the flip side, the most common complication can be hearing loss, because, of course, you are working in that area. And so some structure could be disrupted, I guess. Um, and so it's just good to be aware of that risk, correct?
Yeah, you saw how careful we were with that, but the the volume of perilymph in the human inner ear is about 200 microliters. That's
Wow.
about 5 drops. So you lose perilymph, or you get too much blood in there, you get an inflammatory response. The cochlea is super sensitive. And so about
Right.
25% of patients get a mild high frequency hearing loss. But even those patients will tell you, I don't hear my voice, I don't hear my pulse, I don't hear my footsteps. My hearing is better because I'm not constantly struggling to hear over internal sound.
Right. Fair. Good point. So yes, now my favorite part, last two slides, vestibular rehab, because that's what I get to do to help. Um, has been shown to be, improving patient function and symptoms following repair, because as you've mentioned, they simply have some degree of postoperative hypofunction, right? Some decreased information being sent from that sensor now to the brain for kind of where am I? Where am I in space? What's my balance? So there's some beautiful clinical practice guidelines for peripheral hypofunction rehab. So this is some of the most solid, consistent research we have from a vestibular rehab standpoint on what tends to work. Now you do have to kind of accommodate individual presentation. If they have vestibular migraine, you're probably going to have to back off and start light and build up gradually, for example. But it doesn't mean you can't work folks through who have a hypofunction, even if they have some other variables. So I have this slide here for those who are interested in other complicating factors, concurrent conditions that might kind of change how you approach your vestibular rehab, lighten it up, slow it down, keep it gentle, or I call it read the room, to adjust to your patient. And even what I'll call very specific, visual issues. There's a nice case study by Karen Duren-Grizek about this patient that had a kind of an ocular issue, a strabismus, that was a kind of one more thing because you're like, oh, I want the vision to help. Oh, now the vision isn't as good as we would like, right? So we have these different challenges. I've had patients who also have peripheral neuropathy in their feet, right? And typically I'm trying to have patients use that, proprioceptive information more when they don't have good vestibular information from both sides. So it's kind of work with what you got. Again, one of my mottos, and not forgetting to look for BPPV. So there's a couple studies that I could find that mention that as a possible complication. Yes.
Yeah, it's fortunately not as common as 24% in our group, but we definitely see it. And I think that you saw those plugs going in. There's a excuse me, a pressure wave being
Mm,
sent throughout the entire vestibular system when we do that. We probably knock off some otoconia pretty commonly. They're going to wind up like usual in the posterior canal or horizontal canal, and they respond just fine to appropriate canalith repositioning.
right. So just one more in my endless series of pleas for everyone to just check every patient that comes through your door if they can tolerate it for BPPV, if they have any vestibular issue, even if it's a known issue, like, oh, I already know they are coming to me post-op. I'm just going to start hypofunction rehab. Well, let's just check for BPV because, maybe they didn't have it the day they went to see the surgeon post-op, but now they have it when they're coming to see me once a week. So I'm going to check for that, especially if they're reporting any positional provoked symptoms. So
Yeah,
never hurts to screen. Doesn't take that long, I tell you.
totally
So,
agree. And I will tell you, if a patient calls me, or I always see them a week after surgery, if they're not walking well at that point, it's almost always BPPV is hiding in there, and just got to look.
yep. I hear you, because they might not complain of true spinning. Again, the system's a little bit different, so they
Well,
might just feel
and
off
they're actually
balance.
afraid to lie flat because we've told them, we don't want you to increase your intracranial pressure. So they're a good patient. They're sleeping on a wedge, they're sleeping on three pillows, and they can't tell you that they have BPPV, but they know something's wrong.
Yep, yep, yep. If I had $1 for every time a patient came in and said I feel off, and the cause of off was BPPV, I'd be pretty rich. Okay, so that's it. We have all the wonderful facts about Dr. Carey and how smart he is and how much he's done, and I appreciate him for taking care of these patients. And we in Vestibular Rehab try to do our part because we do not want patients to suffer. We want them to have answers and we want to help them. So that is the purpose of this journal club, to help clinicians and patients to have the best outcome possible. So thank you for being
So
on with us, Dr.
my
Carey.
my pleasure, and I will say, look, you guys are my essential partners in this. It's at both the beginning of the journey and the end of the journey for these patients, because you're super well equipped to find these patients, pull the apples out of the barrel, and send them our way. And secondly, this surgery fails without good vestibular physical therapy. You've got to be able to compensate for that very specific superior canal plug. So, um, love physical therapy. Thank you. Look forward to joining you again.
Sounds good. All right, everyone. Thank you for joining us for Journal Club. Look forward to seeing you next time and take care.